Good evening, everyone, and welcome to our event, Public Policy and COVID-19, with our very special guest, Dr. Mike Osterholm. Our program this evening is the last in a fall series of 6 programs at St. Olaf College on the topic of the presidential election and a nation in crisis, polarization, pandemic, prejudice. My name is Edmund Santuri. I'm a professor at St. Olaf College and Morrison Family Director of the college's Institute for Freedom and Community, the institute sponsoring tonight's event and the fall series just mentioned. The purpose of St. Olaf's Institute for Freedom and Community is to stimulate and support free inquiry and meaningful debate of important political and social issues among students, faculty, staff, and the larger public. By exploring diverse ideas about politics, markets, and society, the Institute aims to challenge presuppositions, question easy or comfortable answers, and foster constructive civil dialogue among those with differing values and contending points of view. For help in organizing our event tonight, special thanks go to Institute Assistant Director Eric Grell and Institute Student Assistant Jess Horst. Thanks also to Jeff O'Donnell, Joshua Wyatt, and the St. Olaf Broadcast Media Services crew, to Andrea Galswick, Dan Hollering, and Carrie Vanderveen of St. Olaf Marketing and Communications, and to Sarah Swenson and Madeline Rush of Goff Public. Special thanks to Stephanie Souchere, 2007 St. Olaf alum, who works at University of Minnesota's Center for Infectious Disease Research and Policy as a news reporter and helped connect us with Dr. Osterholm earlier this summer. Finally, thanks to St. Olaf College faculty and students who have integrated their study with our program this evening, particularly participants in the Public Affairs Conversation program supported by the Institute, and courses associated with the biology department, the mathematical biology, and the statistics and data science programs, and the Center for Interdisciplinary Research. To remind our virtual audience members, you are invited to submit a question at any point during the discussion this evening by using the Participate tab on the streaming page. We are honored to have with us tonight Dr. Mike Osterholm, who is Regents Professor, McKnight Presidential Endowed Chair for Public Health, Director of the Center for Infectious Disease Research and Policy, Distinguished Teaching Professor in the Division of Environmental Health Sciences, School of Public Health, Professor in the Technological Leadership Institute, College of Science and Engineering, and an adjunct professor in the medical school, all at the University of Minnesota. He's also a member of the National Academy of Medicine and the Council on Foreign Relations. In June 2005, Dr. Osterholm was appointed to the National Science Advisory Board on Biosecurity. In July 2008, he was named to the University of Minnesota Academic Health Center's Academy of Excellence in Health Research. In October 2008, he was appointed to the World Economic Forum Working Group on Pandemics. From June 2018 through May 2019, he served as a science envoy for health security on behalf of the U.S. Department of State. Mike Osterholm is also the author of the 2017 book, Deadliest Enemy, Our War Against Killer Germs, in which he not only details the most pressing infectious disease threats of our day, but lays out a 9-point strategy on how to address them, with preventing global flu pandemic at the top of the list. There are many other things we might say about Dr. Osterholm's distinguished career. Can't mention all of them given time constraints. I did want to note 3 more things in the way of introduction. First, Mike Osterholm is generously donating his honorarium for being with us tonight to an endowed scholarship at St. Olaf College to benefit our pre-health majors with financial need. And so the Institute will be directing funds for that purpose instead of handing Mike a check. Thank you so much, Mike, for your extraordinary generosity. Second, last February, the Institute had as its guest John M. Barry, the well-known historian of the 1918 influenza pandemic, author of New York Times bestseller book on the topic, and an expert on pandemics generally. In the Q&A at the end of his presentation, Barry was asked how well prepared our healthcare system was to handle a rise in COVID-19 cases, and he said this in response, and I quote, "Well, you know, I meant to give a shout out at the beginning to a friend of mine, Mike Osterholm at the University of Minnesota, who runs something called the Center for Infectious Disease Research and Policy, and without a doubt is one of the leading people in the world in terms of preparedness and biodefense. My guess would be," I'm continuing the quote, "my guess would be Minnesota is probably strongly influenced by his work, so I would guess Minnesota is probably as well off as anybody." Third, as many in our audience have probably heard, just yesterday, presumptive President-elect Joe Biden announced the formation of his new 13-member coronavirus task force, and that Dr. Mike Osterholm would be a member of that task force. For a while, we weren't sure we were going to be able to pull off this event tonight because task force members were asked by Biden to clear the decks. Dr. Osterholm made some very special efforts to be with us this evening despite his enormous responsibilities. For all these reasons, we are very fortunate, pleased, and honored to have Dr. Mike Osterholm with us tonight. Mike, welcome, and congratulations on your appointment to the Biden team.
Well, thank you very much. It's a real honor to be with you. And as a Luther College graduate, I appreciate the private college Lutheran background. And as I'm on the Board of Regents at Luther, I even appreciate it more today. So it means a great deal. And then, of course, with Stephanie having been a go-between here, she is one of our dear, valued members of the CIDRAP team. So it's a very special evening for me to be here with you.
Thank you. It's good to be on the same team. Mike, I want to start by engaging in what is, for us anyway, an imaginative exercise, but for you likely will soon become real enough if it hasn't become real already. We're imagining that you and the new task force are meeting with the presumptive President-elect Biden for the first time. He wants to hear in detail what people think. He moves around the room to consult each member, and he gets to you and asks, Mike, what precisely do we have to do to get this pandemic under control? Where are we now with respect to the coronavirus? How did we get here? What have we done right? What have we done wrong? How do we get out of this? What would you say to presumptive President-elect Joe Biden in response to that question?
Well, in a sense, that has happened already. So I'll comment in that regard. And, you know, I think that this really is taking a page right out of your book. You know, this is not going to be about the science. It's not going to be about, a public policy as such. Right now, what we need is inspiration. We're hitting the darkest days of this pandemic. The next 8 to 14 weeks, I think, are going to be absolutely horrible. As I said this morning on a CNBC show, we're entering COVID hell. What we're seeing is the rapid escalation of cases. On Labor Day, we had 23,000 new cases reported that day. Today, we reported out 135,000, and the number is going to grow much, much larger than that. Many of our hospitals are overrun already throughout the country, including here in Minnesota. We're having severe challenges. And so, you know, it's not going to be about a solution. What we need is leaders. What we need is an FDR moment. We need someone right now that can tell a story, that can help the American public come together. Those who believe the pandemic is real, but are experiencing the fatigue of trying to avoid the virus, of those who believe that the pandemic was all part of a political hoax that was arranged for purposes of affecting an election. And then, as you pointed out, and looking at the issue of indoor air, the seasons, and the fact that now we're talking about enhancing the risk of transmission, this all couldn't come at a worse time. And so we're not going to have vaccines that will pull us out of this anytime soon. What I mean by that is maybe in the first part of next year, we'll see vaccines for the general public with some limited vaccine before that potentially for healthcare workers. So we're going to have to get through the next weeks and months on our best efforts that are not at all based on science as we think of it in terms of drugs and vaccines, but it's going to be on our heart and souls. And so my encouragement is we need that kind of leadership. We need a story. We need an FDR moment right now.
Yes, that sounds right to me. But how you mentioned vaccines, you know, there was a lot of news yesterday and today about new vaccines emerging and some good news, Pfizer, something about a Lilly's antibody drug. I mean, how do you think we ought to be thinking about these matters now?
Well, you know, sometimes it's a challenge to find good news. It's kind of like trying to thread a semi through a needle. You know, it's not easy. At the same time, there are also times that we work so hard to get good news that we'll take anything that comes along and call it great news. I think yesterday's information on both the new drug licensure for the monoclonal antibody and the vaccine fits somewhere in between, a great excitement and yet cautious optimism. What I'm talking about is if you look at the vaccine, this is a new vaccine, meaning the platform or the way it's delivered, what it does, has not previously been used before. So we weren't completely sure of exactly how people might respond from an immunologic standpoint. And what was reported out yesterday was, in the first read of the data that came in over the weekend, is that there was about a 90% efficacy with the vaccine. In other words, protected people about 90% of the time. Now, the challenge with that is that we don't know what it protected them from. Was it cough, fever, and chills? Was it hospitalization? Was it severe illness? Was it death? And the challenge we have right now is trying to understand that, because if we look at, for example, flu vaccine, influenza vaccine, we know for a fact that the people who are most likely to have severe illness and die from influenza are often those who also have underlying health conditions that predispose them to not having nearly as efficient responses to the vaccine. So, in terms of understanding, are we preventing an epidemic of cough, fever, and chills? Are we preventing an epidemic of severe disease? What does that mean? And so we're going to have to learn that yet. We don't have that information. So it's hard for me to tell you what this means. The second thing is that we are still trying to figure out how to best use this vaccine. And what I mean by that is that never forget, a vaccine is just a vaccine. What's that? It's nothing until it becomes a vaccination, until it's in someone's arms. And we have two challenges on the vaccine side right now with these new vaccines. The two that are likely to be licensed first, or at least approved through whichever process the FDA decides to do that, are both going to be these messenger RNA vaccines, RMNA vaccines. They require to be refrigerated, i.e. frozen at minus 94 degrees Fahrenheit, minus 94 degrees Fahrenheit. There aren't a lot of freezers in Northfield right now that are set up for that. And so one of the challenges we have is, how do we deliver this vaccine? How do we keep it cold right up till the time of use and then make it distributed efficiently? And so that's a challenge. The second thing is it's a 2-dose regimen. So you've got to vaccinate someone 1 month exactly after the first dose, and to be able to set that all up, coordinate it with information, data, et cetera, is going to still be a challenge. And unfortunately, that system is still being built to actually collect that information and to be able to use it. So that's always a challenge, trying to basically create a whole new data collection system on a national basis hours before it needs to go live. And the second point around this is that we still have a very large segment of our U.S. population that doesn't believe this vaccine is safe. I can tell you, in certain communities, in the Black, Indigenous, and persons of colored populations, basically right now, the trust issue around this vaccine is very low. I just participated in a very wonderful program in the state of Maryland called the Barbers Program. And it's a program run out of the University of Maryland, in which many Black barbers throughout the state of Maryland receive special training and information on health-related matters that they share with their clients. And it's a fascinating learning experience for all involved, including people like me. And it turns out that up to 75% of those clients basically don't trust the vaccine at this point. They think that there are inherent dangers in getting the vaccine. So we've got some real issues there. So when you ask me, is it good news or bad news? Well, it's good news in that the vaccine surely did something, but we still have challenges left. The same thing is true with the monoclonal antibody. We know today that based on our best data, that the monoclonal works best if given in the first hours of illness. If you are in an advanced case of illness, in fact, the trials have been stopped because of lack of response. And at this point, when we have a limited number of doses, Regeneron may have 50,000 doses on hand. It's still unclear yet, the Lilly product, but it's not something you can scale up that quickly. And you're already having 100,000 to 135,000 cases a day. You could exhaust the entire inventory in one day. But then how would you distribute it? Who gets it? Who do you decide should get it? Who is going to have severe illness? We're not sure. Well, they should get it, but we don't know how. Then you have to infuse it. This is an hour-long infusion process. This is not something that you can just go into the doctor's office and get a pill. And so you've got to bring people largely to an infusion center, or have a nursing team that can come and infuse you at home. This takes several hours to do. And so you can see that there are a lot of challenges left that we haven't answered about either one of these products. So the good news is we got the products. The question is, how are they going to work?
So we need to be patient on the vaccines. There are a lot of uncertainties, and we need to wait a bit there. In light of the dire projections that you give us with respect to the winter and what's coming and so forth, what is to be done by leadership, by the governors, by the president, by the ordinary citizen? I mean, how are we to be reacting to that projection?
Well, let me answer that in two ways. One is what is likely to happen and how do we respond to it, and what could happen and how do we respond to it. What's likely to happen is we're going to see little change in the federal leadership position right now and what to do. People will really be left to their own devise. I think the issue on state governments are going to be where they'll have responsibility in their own areas as to what to do. As we saw right here in Minnesota today, where the governor of Minnesota basically enacted new restrictions on private businesses, bars, restaurants, etc., to limit transmission. I think that's what's going to happen. That will probably have only very limited impact on what we're going to see. Unless people understand swapping air with someone else is what transmits this virus, and by putting themselves in harm's way that way, I don't know what else is going to stop this. We know that cloth face coverings may reduce transmission to some limited way, and we should use them. But basically, it's being in the presence of others, and we're a society that's how we live. So unless you can bubble yourself up, and when I say bubble yourself up, that's not unrealistic. If you can be with a group of 3 or 4 or 5 other people who all will be, have fidelity to that group and not be going out and being in public places, bars, restaurants, weddings, funerals, etc., then you can get together safely. If not, we're seeing lots of outbreaks right now in home settings. One of the things you can do is love your family so much you don't have a Thanksgiving gathering. College students here, going home. Are you going to go home for Thanksgiving? What assurances do you have that you're not infected and that you're not taking the virus home and infecting mom or dad or grandpa and grandma? And I've seen far too many of these firsthand where that's happened and grandma's dead 3 weeks later. So I think that we have to ask ourselves hard questions about what we do. We're not asking people to do this forever. This is our COVID year. Last year was what it was. It's not going to be the same this year. And hopefully not the same way next year, in the sense of having vaccines. Hopefully by then we can actually change what we're doing, how we're doing it, and get back to what we all want as that normal experience. But this year, think about as your COVID year, the ultimate act of love is not being with a family member necessarily during the holiday season. So I think that's it. The second thing, though, I would say, if I had the ideal answer that I think could really have an impact, is one that I don't see our country having the will to do. And that is, we really do need another, in a sense, lockdown. And people say, oh my God, no, not that. How crazy can you be? If I surveyed 50 people tonight, I could probably get 75 different definitions of what a lockdown is. I don't think anybody really knows what they think it is. And what we've been able to see with clear and compelling evidence from our colleagues in Asia, that if you can drive this virus activity down to a very low level, you can actively use testing and tracing, quarantine and isolation, and virtually shut this virus transmission down. This has been done not just in authoritarian government countries like China, but also even in places like New Zealand and Australia. Earlier this summer, Southern Australia was in bad shape with this virus. They did the lockdowns, they got it down, and they've had a number of days recently with no cases. They brought back the economy. But so how do we deal with the pain and suffering that occurs with a lockdown? And in August 7th, Neil Kashkari, the president of the Minneapolis Federal Reserve Bank, and I wrote an op-ed piece in the New York Times in which we basically said the way to deal with this is to basically pay people, pay to prevail. And what we mean by that is that if you look at the savings rate in this country, we've gone from about 8% of income to 22% of income during the course of the pandemic, because we're not spending money for those that are making it yet. And we have this place to go borrow from at historic low interest rates, that if we were to take that money and invest it back in ourselves and pay ourselves back eventually, we could have an amazing response. So everyone would be held whole. No one who had a job would get anything less than their wages that they had coming. Small businesses would be covered. We would see even some moderate-sized businesses. County, city, state governments would all be covered. Academia would be covered, and even medical institutions. And if we did that, then people would be paid to stay home. Then we could really drive the numbers down and making sure that we had the investment in the public health system. And anybody who says it's either the economy or it's the virus, they don't get it. And in fact, I was very disturbed when all the media exit polling questions were framed around what influenced you more in who you voted for, stopping the pandemic or, supporting the economy. Because you don't have a good economy if you have these cases raging as they are now. I'm telling you, it's going to get much worse, and we're going to see huge hits on our economy. So, you can either take it short term, have the kind of protection program there to support people, or we can let it go willy-nilly like it's going now. And I promise you, for the next several months, we will be in coronavirus hell.
Well, that is a sober assessment of where we are. I want to come back to the point that you made. You said it does, with respect to a total lockdown or another kind of lockdown that would do the trick. It's not a matter of whether you're in a politically authoritarian society or a democratic society, because I was going to raise the general question about whether or not there is reason to think that liberal democratic societies, such as what we have in the United States, are at a relative disadvantage in meeting the challenges of a pandemic like this. And again, I'm reminded here, again, John Barry was here last February, and he said, this is a quotation from the presentation, he said, China was probably the only country in the world that would have had any chance to contain the virus because of its combination of a police state with authority, incredibly high technology geared towards surveillance, towards spying on its own citizens. So China was better situated than any country in the world to do that, and we might add technology here, but we don't have the spying techniques, we don't have the will, we don't have a populace that would obey these restrictions. Now, I don't want to get you in trouble with your friend John Barry, but do you think that he's that's from what I'm hearing you say now, that's an exaggeration, that there is more hope for the possibility of liberal democratic societies to come to terms with an emergency of this magnitude, in your view?
Well, first of all, John is one of my dearest friends. I love the man dearly, and we talk often, and I have the highest regards for him. If this had been a year and a half ago or 2 years ago, I might have given you the same answer John did. I think what we learned, however, was that in countries that had democracies like New Zealand and Australia, you could still accomplish it if the will of the people was there to do it. And that's what it took. And it took the kind of leadership at the local and national level to help support the effort. And they told a story. They told a story about, we're going to get this thing done, get it out of here, and then try to bring ourselves back to some sense of normalcy. And so I think that was the big difference. And so actually I would agree with John. In most cases, it's going to be the authoritarian government that's going to have the best ability to actually, or detect early and drive this down. But we've now learned that that doesn't have to be the case. Now, I think, though, you raise a very good point, Ed. I'm not sure that the rugged individualist in the United States is going to say, oh, yeah, that's fine. Go ahead. I'll go into quarantine or isolation. You can test me, etc. I worry that we don't see the best in humankind in moments like this in our country, that there's a selfishness that I can understand where it come from, but I also don't understand how, when presented with what it does, people would say anything other than, how can I help? And so I think we have a lot to learn from this experience and try to understand, what does it mean about going forward? Because we're going to have more pandemics. Influenza pandemics are still coming. And so I think that this is an example of where we have a lot to learn. I've said over and over again over recent weeks, I feel like we have a 727 going down right now with no humans on board, but 472 black boxes. And we got to recover every one of them and figure out what we can learn from it for the future.
I also want to come back to the point you made about those who lose out, especially in lockdowns, the kind of disproportionate impact on certain vulnerable classes. In a recent podcast, when you were giving advice to people, urging them to find their own bubble, to isolate themselves against infection by congregating only those who haven't been exposed to the disease or haven't had contact with others exposed to the disease, so that means older, vulnerable family members during holidays not being with their grandchildren and so forth. You also said something which really was kind of arresting to me. You said you had nothing to say to the so-called essential workers who could not so isolate. So healthcare workers, people working in supermarkets, delivering pizzas, what have you, or people, you did just address this next point, people who are economically impacted negatively as a consequence of the lockdowns. I mean, do we have a problem of fairness, a problem of justice, equity in the distribution of benefits and burdens associated with this disease? And would that problem be resolved by your proposal that we just pay everybody to stay home? Again, we're still left with the question about people who can't stay home because certain services have to be delivered. I'm just wondering what you're thinking about the equity issue with respect to the consequences of a lockdown.
Well, I think you actually hit it right on the head. This has been my struggle. How do you, even if you pay someone to go to work, how do you protect that family that has a grandmother, an adult daughter with 3 younger kids, and the daughter herself all living in a 2-bedroom apartment and going hand to mouth, month to month to make rent and to have enough food on their table? And she goes to work every day as a nursing assistant at a long-term care facility and gets infected there and comes home. How does she bubble from her family? She can't. That's what I meant by, I wish I could do more. I can't. It's easy if you're a distinguished professor at St. Olaf in Northfield and you live there, you can actually either be hospitalized or you can find ways in your own home to, in a sense, cordon yourself off. That isn't available to so many people. And you hit the nail right on the head. These are often what we call essential workers. You and I want our food. We need our food. We want to have our pharmacies run. So you want to have pharmacy aides, et cetera. And so I think that's what we have to address is the racial inequality that exists in our society. And, this today, I mean, when you look at this right now, 1 out of every 900 blacks in this country have died from COVID since it started, 1 out of 900. And it's a very disproportionate impact hit. So this really goes to the heart of the very discussion we're having right now as a society about systemic racism, about the issues of socioeconomic status and disparities. So this disease is absolutely trouncing on all of those issues that we have and making them worse. So I wish I had the answer, how I could solve that and snap my fingers. But I know one thing is it's absolutely real. I know that it's absolutely critical that we address it. And in this political climate today, I'm not sure how we're going to do that, but failure is not an option here. And I hope to be able to look back one day on this and think back and say, boy, that was a tough time, but we got through it and we're better for it. And that's my great hope.
Another, I suppose, devil's advocate question, if I might. And this would be a question that be posed by proponents of, for example, the so-called Great Barrington Declaration, scientists associated with that. Critics of lockdowns who say that the cure is worse than the disease. And if I might suggest, they see people like Mike Osterholm or John Barry as what might be called pandemics absolutists. That is to say, people who are narrowly focused on the evil of the pandemic to the exclusion of enormous trade-offs. For example, the evils brought about by lockdowns. So just to take one instance, one defender of the Great Barrington Declaration, a woman named Janine Eunice, cites in a recent article, an Oxfam study that concludes that 130 million persons will be brought, quote, to the brink of starvation as a consequence of the supply disruptions caused by the lockdowns across the globe. And that's roughly, according to this argument now, 30 million more than the projected deaths that would be caused by the coronavirus itself. And she and others also cite this, I've seen this analogy cited in a number of different contexts now, traffic deaths, which are about 1.35 million per year, which could be avoided if we ban driving cars, but we don't do that because of the trade-offs. And so proponents of this great Barrington Declaration, not just those people, but those who are sort of in the same worldview, argue we should adopt focused protection of those who are most vulnerable, the elderly, those with underlying conditions, where that is feasible, and everyone else, the young and the healthy, ought to return to normal life so that we can move expeditiously and aggressively toward herd immunity. I put the question to you, what do you say in response to this view that you're zeroing in on the pandemic in isolation, in abstraction from other larger considerations that are just as important to take into account?
Well, let me just begin by saying this concept of herd immunity as a way to slow down the transmission of the virus is a real theory that we all want to achieve. It's a matter of how we get there, through vaccine or through natural disease. So let me turn this on the master and student here, Ed. Let me ask you, what have we locked down in the last 2 months in this country? What's been locked down? Can you tell me?
Well, I'm thinking mainly...
What's been locked down?
I'm thinking mainly in the spring when there were constraints.
What's been locked down? Nothing. The decisions have been made voluntarily by institutions. Air flights right now, nobody has kept anybody from flying on planes. Yet traffic is half or less than what it once was. The very impact of the pandemic is what's shutting things down. So when we talk about the Oxfam studies, those weren't from lockdowns. Those were from people basically not involved with commerce because of the pandemic. We can't get drugs right now from India in any meaningful way. We have big shortages. It's not because of lockdowns, because so many people have been sick. So when they say these things, they're just simply not true. I mean, that's why I ask people, tell me what's in a lockdown right now. Help me understand. Okay, you may have only half the number of people that can attend a restaurant. Okay, but in so many cases, what's been ascribed as the pain and suffering isn't related to the lockdown, it's related to the disease. The second piece of it is, unlike others, I'm the one that's proposing how to solve the problem of the pain that does occur when a lockdown occurs. Is the fact that keep people whole. I've given you the exact economic model how to do it, and I'd have to say my co-author, being the president of the Federal Reserve Bank and one of the lead presidents in the Federal Reserve System on COVID, should give you some sense that this is probably just not a harebrained economic idea. Has anybody moved on that? What if we could hold people whole? What if we could hold businesses whole? What if we could help St. Olaf try to deal with its deficit it's dug itself into because of this pandemic, as has higher education across the country? So I think that one of the challenges I have is we have a lot of what I call academic pointy heads, and I come from an academic world, who have these wonderful grand arguments when in the first instance you hold them to the light and they don't hold. They just don't hold. Right now, you know what's killing people? It's going to kill a lot of people. COVID is one. But number two, when your hospitals are dysfunctional because they're overrun, because we don't have enough staff right now just to cover what we have going on in our hospitals now, and it's going to get a hell of a lot worse. Do you know what it's like to have a heart attack in a situation like that? Do you know what it's like to have a stroke? Do you know what it's like to have a septicemia or a bacterial infection of your bloodstream? Do you know what it's like to have a very complicated pregnancy? Those are all functions that are going to be severely limited because of COVID. If you don't control COVID, I don't care what else happens, you're not going to be able to control those. That's the part that's missing, is we don't have an honest and realistic evaluation of what happens in our communities. Shutting down COVID means that those supply chains don't get separated. It means that they don't end up not happening. Even in this country, I think we went way overboard last spring, and not by anyone's fault, but we deferred a lot of medical procedures, some that should never have been deferred. They were emergency cancer issues. They were situations where pregnant women needed to have in-office visits because of perinatal issues. I'd be the first to say that, and we're getting better at that. I think this time around we're doing much, much better at that issue. But that wasn't because of lockdowns.
Yeah. So
and I think that's the choice.
Yeah. So anything that you're proposing with respect to lockdown would still be open to the possibility of these other medical conditions being addressed. You're not proposing.
Oh, absolutely.
Okay. All right.
See, that's why I said if you interviewed 50 people, you get 75 different definitions of what a lockdown is. So you and I could go at it, and we could get 6 more people involved, and we could create mass confusion of the highest academic order, because all 7 of us would be talking about something different to each other, but knowing full right that we were right and they were wrong, and we didn't have any idea we were all talking about something different.
Interesting. Of course, we've been talking mainly about the response to this particular COVID-19 crisis, but you have talked quite a bit, too, about the larger macro problem, long-term systemic preparedness by societies for pandemics that you project. As you indicate in your book, and as you have reiterated in a recent essay you published last summer in the journal Foreign Affairs entitled Chronicle of a Pandemic Foretold, apart from the present COVID-19 crisis, there are larger questions of general systemic preparedness for any potential pandemic. You say COVID-19 has been bad, but it might not be, as you say, the big one. And there will be a big one eventually in your estimation. I mean, given that reasonable certainty, or at least that very high probability, what must the country and the world do for a general, national, or global systemic preparedness for pandemics like this? Things that have not been done.
Well, I think you did a nice job laying that out. Thank you. First of all, it's about situational awareness. Right now, most people don't have a sense, or didn't have a sense, I should say, that this could happen like it's happening. I mean, even now, there are people who are shocked, because remember, it was just 8 weeks ago, we thought this pandemic in the United States, at least, was going away. Now we've seen what I've been saying all along. I've been criticized frequently. In fact, the governor made a joke about it today at his press conference about my calling innings, and the fact that I said we're in the bottom of the 3rd, top of the 4th inning here, and we've been here for some time. And I said I wouldn't go any further than that until we got through this next period. I predicted this next period was going to happen as it's happening right now. And I think that if you go back, our center, and I specifically called this on January 20th and put out a statement saying that this was the cause of the next global pandemic. It was going to be very severe, and we needed to be ready. We needed to prepare as much as we could, a month or 2 of preparation before it was a full-fledged crisis in many countries in the world. On January 20th, the day that I put that document out, 2 months before the World Health Organization basically declared it a pandemic, I went and met with senior leadership at 3M, a company who is by far the world's leading expert and manufacturer of N95 respirators, those tight face-fitting respirators that we need so badly to protect healthcare workers and others from this virus. For weeks and weeks, they went, and they started the next day on the 21st of January, running every machine in the world they had 24/7 to make N95 respirators. Millions of them were made in advance of even the U.S. government contacting them. We weren't moving quickly at all because people didn't believe this could happen. From January 20th until February, roughly 20th, when I wrote another op-ed in the New York Times saying, this is a pandemic, get on with it. We've got to understand we've got a lot of preparedness work to do. You can't know how many public health people, how many other people in the public, how many academics basically chastised me quite publicly for scaring the hell out of people. And, here goes Mike again. And, they didn't want to believe it. In fact, one medical journal took out a full-page cartoon in their journal comparing influenza to COVID-19 and showing how our efforts were so misplaced and concerned about COVID-19, we should be thinking about seasonal flu. Well, that kind of situational awareness obviously gave way, and finally in March when people began to see it and now understanding what it was. And ironically, some of the people who are now the talking heads on COVID-19 were some of the people who were most critical back at the time that I first said this was going to be a pandemic. But what this really speaks to is that we just don't have a sense of the vulnerabilities today and why we have to be prepared for them. For example, you talked about the big one. As John Barry shared with you, no one knows influenza pandemics better than John Barry. And, 1918, if it were to happen today, would be much worse than we see with even the COVID because of the impact it would have on young, healthy adults. Well, I don't know how many people are aware of the fact of this, but right now, as we speak, there are 23 billion chickens on the face of the earth to feed people. Protein needs by far the most efficient conversion of energy to protein. Those 23 billion chickens make up half of all the avian body weight in the world. There are over 390 million pigs on the face of the earth right now, many of them co-located with the chickens. Well, we know from an influenza standpoint, if you wanted to create the ideal mixing vessel, you would put chickens, which actually are avian influenza virus carriers, which are the seed viruses usually for an influenza pandemic, and then co-mixing with pigs, which have the unique ability to actually have both human and bird viruses infect their lungs, where you can swap out the virus genes quite nicely and create that new pandemic strain. Then you put on top of that 8 billion people and global travel, and you know what? I couldn't come up with a better witch's brew for coming up with an influenza pandemic. It's just a matter of time. The second one we have right now is an insidious one that isn't overnight, oh my God, but it is day after day after day after day. That's antibiotic resistance. My great-grandparents and grandparents grew up in a pre-antibiotic era. I've lived mostly through an antibiotic era, but I guarantee you my kids and grandkids are going to live in a post-antibiotic era. We have basically used up almost all the antibiotics that we have readily available, and resistance has developed. And we are in a situation today where the infections that we commonly assume can be treated readily with an antibiotic won't be treated in the future. And it's not because we just, basically haven't been concerned about it. We haven't invested a lot in it, but we've kind of assumed that, well, the private sector would just take care of it and make more new antibiotics, or that we'd use old antibiotics more wisely. Hasn't happened. So I think that if I had to come back to your question is, we won't get prepared until we begin to understand the impact that these pandemics can have. I do think that this is a teachable moment more than I can tell you. I think people are now getting it, what this pandemic has done. And dare say that, I can only hope the whole world learns from this. But, it's just like the Defense Department. When's the last time you heard of the Defense Department putting out on contract bids for missiles the afternoon they go to war? No, they have a response all planned. They have the tools, they have the weapons. We pay for them as a matter of international security. We've got to start doing that for public health. What if we'd had all these vaccine platforms ready to go and had this coronavirus come up in that time? We could have made these vaccines and had them approved within days as opposed to months and months. Think what difference that would have been. Well, I don't know why we couldn't have done that. We in my book you cited, Deadliest Enemies, chapter 13, SARS and MERS, a harbinger of things to come. We talk about it right there. We don't need creative imagination to know that this stuff was coming.
Yeah, you say in the article too, in the Foreign Affairs article, I'm quoting now, had the requisite financial and pharmaceutical resources gone into developing a vaccine for SARS in 2003 or MERS in 2012, scientists already would have done the essential research on how to achieve coronavirus immunity, and there likely would be a vaccine platform on which to build. Today, that would have saved many precious months or even years. But your critique, I think it's important to note, your critique is extending not just to the current administration, but back all the way to previous administrations that have not positioned us well in terms of the infrastructure to move in the right direction. And that just brings me to one question before we go to general Q&A. It's a kind of deeper philosophical reaction that I have to reading your stuff and other people's stuff about things. I mean, is there something chronic in human nature, in your view, that prevents adequate preparation and response? Do civilizations generally have the wherewithal for planning, given their capacity for self-deception or inabilities to see beyond the present moment? I mean, in this article that you published, the Foreign Affairs article, you talk about this phenomenon called hyperbolic discounting, drawing on the work of a guy named Eric Delzal. You say, you quote, leaders do what is easy and pays immediate dividends rather than doing what is hard, where the dividends seem remote. With something like a pandemic, which sounds like a phenomenon from another century, it seems too remote to plan for. And then you even quote Daniel Defoe in Journal of the Plague Year in 1665, saying even there the response was inadequate and there was a lot of denial and so forth. It's hard not to come away from this sensing that humanity has a hard time learning the lessons that it needs to learn. What is your disposition toward all of this? I mean, do you ever throw up your hands and say, "My goodness, there's something about the human condition which just makes it resistant to learning in the way that it should learn about these matters"?
You know, I don't throw up my hands, or I guess I wouldn't still be in this business trying to do something about it. But at the same time, you know, never waste a good crisis. And that's what I think we all hope never happens, but that when it happens, we have to take advantage of it. And so I don't think that we had been in the position, regardless of whether it was Democrat or Republican, whatever, to really understand the threat from a pandemic perspective like we are now. And I think that makes a difference. I'll give several examples. You know, in 2005, there was the concern that H5N1, influenza bird virus, was going to basically spill over into humans. We had a number of human cases, you know, kind of one-offs that didn't continue to transmit on in any meaningful way. And, you know, the world got very concerned. You know, everyone was poised for the next influenza pandemic, and then it didn't happen. People said, "Oh, what the hell? That didn't happen. That wasn't a big deal." Same thing happened with Ebola in 2014. Ebola was a major situation in Western Africa. Some thought that it was going to become a worldwide epidemic pandemic. You know, people like myself saw that that was never going to be the case. But again, it gave people the sense, oh my, we were under attack, and then it kind of went away. Well, that wasn't so bad. And so when you have these situations like this, even SARS in 2003, you know, got it under control. So it gave people the sense that we had the upper hand on all the microbes. You know, no matter which battle we got in with them, we'd eventually win. I think it was only with situations like this, with COVID, that people have now woken up and said, oh, this is what it's really like. This is what you're talking about. So I think this is a very important moment. It's an inflection point in how we think about this, what we are able to accomplish with preparedness. You know, people will never want to get caught short again on this, never. Companies won't. Companies are taking huge hits in many ways on some of these issues. And so I think that you know, academia won't ever be the same again in many ways. And how look at distant learning and, you know, campus, off campus, you know, cost. Think of the cost to it that many institutions are going to have to try to dig themselves out of. So I'm at that point where I think that, you know, we will learn a lot from this that will make a difference. We will have changes that will occur in the future, and we will see much more of a military type model, meaning that, you know, we will pay to be prepared because it's like insurance. The cost of not being prepared is there. And I just come back to, you know, sometimes events one day can change the world. Look at 9/11. Has it been the same getting on and off a plane since then? Security is totally different. For younger students, they wouldn't even know a time when you and I could just walk on a plane without any other searching of any kind. No TSA, no nothing. So I think that this one will be our 9/11 kind of moment, and it's up to us to use it to better prepare the world so for future ones, which are going to happen for sure.
Thank you, Mike. I think now is a good time to move to general Q&A, and we have some questions from St. Olaf students via video, and so let's move to the first question.
My name is Martha Barnyard, and I'm a senior math major with statistics and mathematical biology concentrations. I'm asking this question on behalf of mathematical biology and the Center for Interdisciplinary Research. In the beginning of the pandemic, the limited case data and unknown proportion of asymptomatic cases made predictive modeling for COVID-19 difficult. As our testing capacity and our knowledge of the disease has increased, how has the use of predictive models and policy decisions at the state and national level changed? In addition, how can epidemiologists clearly explain the results of these models as well as changes in the dynamics of the pandemic itself to the public at large?
Well, it's interesting you should raise that. I just recorded a podcast earlier today in which I was very critical of modeling, just so you know. We have a situation right now where we have modeling exercises going on by particularly one group at the University of Washington that project out months in advance on very, very limited and at best highly flimsy data, yet it makes for great news. And, it's how many cases will die, 3 months from now down to almost the decimal place. And also what will masking do with a high level of definition there for months and months to come in terms of deaths prevented. So, my sense is that modeling is all wrong, except some of it can be helpful. And I think that it's the humility that needs to come into this, just how much of the variation can be explained and what can it mean. And I think that we have seen, for example, the modelers who got involved early into this disease process actually created some models that made for a horrendous number of deaths, hundreds of thousands of deaths when 2,000 occurred in a given area over the time period that had been projected. Again, a credibility issue immediately. You just scared the hell out of everybody when, in fact, we knew these deaths would occur over time, maybe not even that many, but that would be a sizable increase in deaths. We saw that with Ebola, as I pointed out. In 2015-16, the Ebola outbreak in West Africa, the CDC projected that there would be as high as 100 or as high as 1 million deaths in just 2 countries in that limited time period right there, where the WHO indicated that their findings were that there would be about 20,000 cases in 3 countries during the same time period. Well, depending on which model you believe, one just scared the hell out of you. The other one was, okay, that's bad, but we can deal with it. Well, unfortunately, fortunately for the world, it was the WHO model that was correct. But I got to tell you, for people like me up on the Hill in Washington, trying to face the accusations that we had basically scared people needlessly over this issue, that we had tried to hype it as such, was a real challenge. And so I think that one of the things I hope everyone learns in undergraduate and graduate is how to explain modeling and to explain both its limitations and its strengths. And far too often that doesn't happen. You can explain 7% of the variation and suddenly you now have an answer. So I don't want to be discouraging of modeling to you, but I want to put up a level of responsibility that I think is really very important and must be met. And that is explain what you know and don't know. And in the early days of the pandemic, it was very hard to get some of the data that we wanted to have, and not just hard in the sense it wasn't being shared, but it wasn't collected. And so we're still in that process of trying to understand and learn that kind of situation of what we can learn from these data. So I think if anything, this pandemic has also taught us the need for humility around modeling and what it can and can't do. And while that's not a popular thing to say in the modeling world, I'm absolutely certain it's the truth.
Thank you, Mike. Next question.
Hi, Dr. Osterholm. My name is Abby, and I'm a junior nursing major here at St. Olaf. In light of COVID, what advice do you have for pre-health students? Does training or curriculum need to change for students going into these fields? Thank you.
Well, first of all, thank you for going into the fields. We need you. We need you very badly. We're going to recognize also that in a time like this, medical practice needs to obviously change to the demands of the time, but there's some things that you just can't change. And what I mean by that is that an intensive care doctor, nurse, respiratory therapist, other team members in the intensive care unit are uniquely trained. They are people who are highly, highly skilled. And I surely do not take anything away from the hospitalists or the family practitioners who are in our hospitals. They too do, incredible work. But if I came in tonight with a major head trauma and I had a choice between the hospitalist or the neurosurgeon of doing it, which one would I take? You probably know. Well, what we're doing now is we're asking people to work out of their area of expertise. We now have, in the Twin Cities metropolitan area, we have young adults now being admitted to pediatric intensive care units for tiny babies, practically, in terms of COVID care because we're so short. We're seeing that the ability to actually staff beds for people with intensive care is severely limited. And what this really points out is the need to really reassess our training programs and what do we need and what can we pay for and how do we pay for it in terms of being prepared. We don't pay to train the fire department at the Minneapolis-St. Paul International Airport to really, hopefully never have to attend to a plane crash. Do you know that after all these years, there's never been a major plane crash actually on the grounds of the Minneapolis-St. Paul International Airport? The planes that have gone down in South Minneapolis. And yet we pay large dollars every year to make this one of the best well-funded fire departments in the state of Minnesota. And I'm glad we do. I think it's great. But we pay because we understand the risk. So I think in the healthcare side, I would hope that we have a reevaluation of what we need and how we need it. We make it so that we can continue to help support healthcare students in the healthcare sciences so that they don't get out of colleges with these huge debts and realize that this is all a community service to their country, to their communities to do this. So I've never been more bullish on healthcare careers. The one thing I would say, I am also, though, at the same time, want you to be aware that we need to do a lot more to protect you. We have left healthcare workers far too unprotected during this pandemic. In large part, we just didn't have the protective equipment handy or were able to purchase it quickly and so forth. And so we do have to do much more work in that way. So until we do a better job, please keep yourself out of harm's way.
Thank you, Mike. Next question.
Hi, Dr. Osterholm. My name is Emily, and I'm a junior nursing major here. And my question for you is, the current political climate has exacerbated concerns over the legitimacy of science. How do we overcome that, and what is the role of students in overcoming that? Thank you.
Boy, thank you. Great questions. I love good liberal arts education. We have a real challenge right now in terms of the science world. I don't have any other way to say it. When you can attract 1,400 people to a convention in Dallas each year who are there because they believe the earth is flat and it's a flat earth society, I'm not making this up, it's real. You got a problem. When you see the kind of issues today that come up around vaccines and the anti-vaccine movement that clearly misrepresent and do more than distort. They actually intentionally lie about data around vaccines. You got a problem. And so I could go through a laundry list of issues like that, whether it be climate change, whatever. And, science literacy is something that we used to think was just a function of more education. You just got to tell people more. And we're realizing that's not the case at all. Today, we in science are going to have to do a lot better job of keeping our mouths smaller and our ears bigger to understand why is this that people don't believe in science. I can't begin to tell you. Just in the recent time, we've had situations where individuals who come from families where COVID is a hoax, and someone ends up dying in the family from it. Well, they actually had pneumonia with the COVID virus. So the family said, well, they didn't die from COVID, they died from the pneumonia, not realizing, well, the underlying cause was COVID. And you can say, how could you deny that? So I think that it's a challenge right now that we don't know quite. Well, I don't say we don't know how to deal with. And we're all trying to learn and do a better job of understanding what we can and can't do with the science literacy. It's a large area, and I think you're going to see over the course of the next few years whole disciplines develop around the education, the research, and the understanding of kind of the anti-science movement and what it means to making good, sound decisions for public policy, for our everyday lives. Is how do we make good science decisions?
Thank you, Mike. Next question, please.
Hello, Dr. Osterholm. It's a great privilege to get to ask you a question. I'm Pravesh Paudel, and I'm a junior at St. Olaf College, and I'm majoring in mathematics and computer science. I actually had the pleasure of attending one of your talks during this summer while I was working as a summer health scholar with Dr. Bill Stoffer. And my question is that we've been hearing the news that COVID-19 vaccine is going to be out in a few months. How are they going to be mobilized in the United States, and who gets the priority? Does the United States government have a plan? Obviously, it's going to take a few months for a significant percentage of the population to be vaccinated. What is our country going to look like during that phase? Also, we never know if the vaccines are going to be 100% effective. Are we assuming a lifetime immunity or a 4 to 6 months immunity during which we expect the virus to go away? Thank you.
Well, thank you for that extended question. Now that I have the next 3 hours, let me go at it. I covered a lot of this already earlier tonight, but let me just go back and reiterate it. Number one is, yes, the vaccines are here. We're working on them in terms of final approval. The mRNA vaccines will be the first to market. We are developing plans. There are prioritizations, which right now put healthcare workers and individuals at high risk for serious disease at the top of the list. Also taking into account racial disparities, race and ethnicity, SES, that kind of area. So that is all in the works. The plans are being developed to roll them out following the recommendations of the Advisory Committee on Immunization Practices from the CDC, that then are basically shared with the states, and they, together with local partners, make the final decisions how they'll roll out these vaccines. At this point, I think it's fair to say that, as I said earlier, it's going to be a complicated rollout in terms of the refrigeration issues. If we're trying to vaccinate healthcare workers, at the same time they're all overwhelmed with a number of cases of COVID, it's going to be hard to coordinate vaccine programs at the same time trying to vaccinate healthcare workers. I think that we'll have enough vaccine to vaccinate the U.S. population sometime by the second quarter of this next year. That assumes people will take it. And I think we have a lot of work to do yet to convince any number of individuals that this is a good thing to do. So we do have a plan. It is being developed as we speak, but I think we're a long ways from actualizing that plan yet.
Thanks, Mike. Next question, please.
Hello, my name is Lauren Mossman. I am a junior math major, and my question stems from the politicized drama wearing masks has become, even though scientists continue to provide evidence that wearing masks saves lives. What are other countries doing to motivate their citizens to wear masks? And can the United States implement any of these strategies in the months to come? Thank you.
Yes, thank you. Well, let's just be really clear. When we talk about respiratory protection, it is very important. And if the whole world could wear an N95 respirator, the tight face-fitting device that doesn't allow leakage around the sides, it actually has a type of material that's a poured material that hardens. It forms the actual face mask, as people would call it. It has an electrostatic charge in it that actually, as the air comes through, it captures the virus. Otherwise, it would be more like cellophane trying to breathe through that very, very thick material. Those are by far the ideal. They prevent 99.9% of the viruses either getting in or getting out. So if you're there. Surgical masks are those which are designed for surgery as such, and they're much more loose fitting. They actually have vents on the side that are open if you've seen them. Many of you wear them. And while they'll contain larger droplets being spewed out, they don't necessarily contain the aerosols. The aerosols are these very, very tiny droplets that I liken them to the BBs, whereas the droplets are like the bowling balls. And these aerosols will float in rooms forever. Think about the fact that if you're in a department store and you're 4 aisles away from the perfume section, you smell perfume, that's an aerosol. You're walking along a street and all of a sudden you smell smoke and you look up 40 feet in front of you, somebody walking ahead of you smoking a cigarette. Those are aerosols. They float and float, and particularly indoor air. Just me tonight being in my office, I've been in my office today, I don't know, about 16 hours talking the whole time. That's why if I'm sounding hoarse now, I probably am. And this room is filled with my aerosols right now. It'd be almost like an aerosol bath. And so you have to have the protection to keep those out. Well, when you get to face cloth coverings, the data doesn't really exist supporting that they work. And in fact, there was a study that just came out supported by the Center for Medicare and Medicaid Services by Health Quality Research Group at Oregon, University of Oregon, who have been following this, who said just that last week. And we conflate basically putting respiratory protection devices like N95s, surgical masks, and face cloth coverings. They're often lots of space around them. The cloth is not like an N95 respirator that basically traps the viruses in there. And what data we have right now supports that probably they're less than 50% effective in keeping aerosols from coming in and coming out. So they're a dose reduction effort. So I tell people to wear a cloth mask, a face cloth covering, but don't count on that as being your source of protection. Think of it more like if you had 15 pieces of Swiss cheese stacked on a table, hopefully you wouldn't see any space on the table. All the holes would be covered by one or more of the pieces of cheese. That's what a face cloth covering does. And so, it's unfortunate they got politicized. It was terribly unfortunate. And it became almost either you were for prevention or you were against it. I think there was a lot of rhetoric around it from people from our side of the public health world who said if we all just wore a mask, we could drive this down in the ground in 5 to 6 weeks, which is absolutely no basis for that. And we never distinguish between what we're talking about. Many of the studies that get cited as for how well these work are N95 respirator studies. They're not face cloth coverings, and they're in healthcare settings. And so I only point this out because I don't want people to be confused. I say wear your cloth face fitting, but please, most of all, distance. Distancing is important. Swapping air with someone is how we transmit this virus. We've had far too much hygiene theater. Hand washing is great. I deal with a lot of other infectious diseases where hand washing is really important. But please understand that that's not an important mechanism for the transmission of this virus. It's swapping air. And so, my face cloth covering may reduce somewhat the amount of virus I inhale in, but if I'm in that environment long enough, it's going to ultimately, with enough dosage of the virus in the air, I'm still going to get infected. And we worry today that we have more and more people who just count on that as if it's an absolute source of protection, and it is not. So wear it. It's helpful. But how helpful, we don't know. And at this point, don't count on it as being your only way of protecting yourself from getting infected.
Thank you, Mike. I think I'm going to take some questions now from the live feed, and I'm going to pose 3 of them to you because they all sort of revolve around the Biden task force. The first one is from Kathy Lindsay from Lacey, Washington. So maybe an alum, I'm not sure about that. What will be your role on the COVID task force Biden has convened? A second question, this from Mary Sage Kirwin, class of 1977 from Colorado Springs, Colorado. To what extent will President-elect Biden's administration be leading a national effort to address COVID-19, and what proportion of that will be left to states and local governments? Thank you. And then third, from William Way, class of 2021 from St. Olaf College, what is the most immediate change you wish to implement after joining the President-elect Biden's task force?
Well, thank you all for those questions, and thank you for your interest in this issue. I hope you can understand, we've basically have been now officially part of this task force for 2 days. And we've had one meeting, And at this point, I'm just not in a position to comment much beyond saying that, we're working on it. I'm excited by my colleagues that have been included in the task force. We met with the president-elect and the vice president-elect and have had discussions about what the key issues are. So I'll say at this point, I'm optimistic that this will be a very engaged administration in COVID. The challenge we have, of course, is they can't do much until January 20th. In the meantime, I think that, the kind of plans to make sure that they hit the ground running in triple speed on the 20th is absolute. And I think that anything they can do to help organize or further support planning at the state level, as one of the questionnaires asked, it's a very good question. Should we leave this all up to the states? Is there a way that a national coalition of experts can come together to help guide states in what they do and where they go? So I wish I could tell you more. Come back in another couple of weeks or a couple of months, and I promise there will be more.
Well, we'd love to have you back, Mike. Next question, please.
My name is Rafa. I'm an international student studying nursing. You've recently joined Joe Biden's COVID task force, and therefore you play a key role in changing the narrative of the coronavirus pandemic. Based on what I've read, you are realistic, but also hopeful about the course of the pandemic. And you argue that we can have it both. We can have both health and economy. And I understand that you have just had one meeting with the COVID task force, so this may be premature. But my question is, what measures are you planning to take or hoping to take to regain people's trust, to reorient people from the mindset of it's us versus them to it's us versus the virus? Thank you.
Yeah. Well, thank you. That was actually a very thoughtful question in the sense that the other ones that were asked were also good too. But, let me come back to a point I made earlier when, Ed, you asked me right out of the chute kind of what I would do if my first recommendation to the president-elect. At this point, we as a nation have to start having a dialogue about this. And I know that sounds very generic and, wonderfully nondescript. But what I'm saying is that we don't have a storyline. What are we trying to tell people? What are we trying to do? Is it government versus the people, or is it government versus the virus? Is it people versus the virus? Is it people versus people? And I think that what we need to do is lay that out. For this week's podcast, I actually took one of the FDR fireside chats and read part of it at the conclusion of my podcast. And it was all about how to bring a country together, how to anticipate what was going to be so very, very hard and challenging. But rather than throw up our arms and say, it's your fault or it's your fault, it's not my fault, or to say that we can't get through it, is to say, you know what, this is going to be really bad. This is going to be really bad, but we can get through it. We can get through it, and this is how we're going to do it. And we all need to, come together to do this. And so I think that if I bring anything to the task force, it's the fact that we have got to share with the public our story. What are we trying to do? How are we trying to get people to a vaccine as opposed to getting them to this concept of herd immunity through, a natural infection? And so I think that, this is a part where I've said before, I think in our world of science, we need to have a smaller mouth and bigger ears. We need to listen right now. We need to understand what people are thinking, what they're feeling, and then we tell it back in a story. And that's what I hope that I can bring. So that surely still means science is very important. Public policy is very important. The truth is the truth. But we have to reach people at a place where they will respond. And it doesn't help to be so smart and so wise and nobody believes you and doesn't do anything you tell them or suggest they do. And so that's what we have to really work on.
Thank you, Mike. This is a question from Claire DeWind, class of 2015 from Brooklyn, New York. Earlier this year, you mentioned working with others to develop a reusable N95 mask. Is that still in the works?
That is still in the works. Thank you for that question. We are working on that with a group from California. and they've run into a few snags in terms of how to manufacture it. But the technology they've developed is one where, remember I talked about the N95s having the electrostatic charge, so that as you breathe the air in and out, it moved relatively easily because the space was big enough. But as the virus came through, like on a filter material, it was like a magnet and pulled it right into the filter material and didn't let it pass. What they're trying to do is build a device like that, in a sense, a type of mask that could actually be washed up to 300 times and not lose its electrostatic charge. And so that project is still ongoing. We all wished it would have been done months ago. And clearly from a timing standpoint, every day that we don't have it is an unfortunate loss of life. But at the same time, they're working as quickly as they can. And this problem is going to be around for a long time. This is not going to go away tomorrow. I mean, we've looked carefully at the capacity worldwide to vaccinate the world. And to vaccinate the 8 billion people, if we don't cannibalize childhood immunization manufacturing, it would still take us well into 2023 before we'd have enough vaccine for the rest of the world. So, we're going to have a need for a vaccine and still these kinds of respiratory protection. So thanks for the question. It was a great question. And don't think I'm not on it every day wondering where we're at. I'm like a kid at Christmas, and I can't wait to get downstairs and open the presents. Let's get those masks.
Thank you, Mike. This from Chris Bretoy, St. Paul, Minnesota. In your book, Deadliest Enemy, you talk about tick and mosquito vector-borne diseases. What do you recommend for persons suffering from chronic Lyme disease and co-infections? Why has the medical community failed to acknowledge Lyme disease and co-infections in its chronic form, that is, post-acute? It is a stealth bacteria? Question. The acute antibiotic regimen, while effective for acute Lyme, is totally ineffective for chronic Lyme. Why has there been so little attention to or funding for vaccines targeting this disease in spite of its long-term debilitating effects?
Well, let me say, first of all, there has been work done on vaccines, and there was actually a licensed vaccine that was available 15, 20 years ago, and nobody in public bought it. So it went off the market. And it was terribly unfortunate. It was a vaccine that had relatively good effectiveness, and maybe one day it'll come back. You're not going to want to hear this, but I am one of those who does not believe that chronic Lyme disease exists. I do not, for a moment, dispute the fact that people have some illness, that there is something going on. And in fact, we see with COVID, the situation right now where we have people who have very mild infection initially in terms of illness, who 5-6 weeks later develop a very severe debilitating chronic fatigue syndrome like picture, brain fog, etc. Again, we don't have any evidence the virus is doing it. It set up the system to do it, which is your own immune system. There have now been a series of double-blind randomized placebo-controlled trials where people who insisted that acute antibiotics and chronic antibiotic use basically were both necessary. In this case, in chronic antibiotic use, people insisted that they only could feel good if they were on antibiotics because of their chronic Lyme disease. Yet, in these 3 double-blind randomized placebo-controlled trials, for which neither the investigators or the people were enrolled, half got actually IV antibiotics, half got IV shams. And in all 3 studies, the results were no different. People had the same recovery with saline as they did with antibiotic. And so people don't want to hear that. They get very upset and say, well, you're just one of those people that don't get it. And, there's no evidence that Borrelia burgdorferi as a Borrelia bacteria is any more difficult to kill in the body than any other organism. They're not hiding in some cryptic location. Have they triggered a part of your immune system that may have a chronic ongoing challenge? Absolutely. And that's why I say I believe in the condition. I don't dismiss that. But I have actually seen patients. I'm now aware of 2 patients I knew who both have died as a result of ongoing IV antibiotics and developed super bacterial infections because of the IV antibiotic use that was really a tragedy. So there's a downside to treating these people with this. So again, I urge you to seek the kind of care that can assess what's going on from immunologic standpoint. But for anybody out there, I'm absolutely convinced that chronic Lyme disease, as evidenced by ongoing infection, does not exist.
Thank you, Mike. This from Jessica Horst, class of 2022. She is also a student associate of the Institute for Freedom and Community at St. Olaf. Do you think that college students will be returning to campus in the spring, or are we more likely to be asked to study remotely again?
I have almost no hope that we'll be back in the spring. I think going into the holiday season, it's going to be tough. By the time we get vaccine rolled out and potentially, start to see reduced transmission in college settings, we'll be at least midway through the spring semester at the earliest. And then I don't know if people would come back or they would continue their programs where they're at. But, again, I can't say this with any more clarity. The days ahead are going to get much tougher. We have not seen the toughest days of this pandemic yet at all, not even close.
Thank you, Mike. This is from Chris, class of 76 from Minneapolis. Can you talk about how the coronavirus pandemic is aggravating ageism?
Well, I think, first of all, thank you. This is a really good question. It's a very important one. I'm one of those people that, I don't, how should I say this? I don't try to judge others by what they believe or think unless it hurts someone. I think at that point, then that's wrong. But if they have certain ideals and beliefs, but I have a real problem with the issue of the quality and quantity of life issue. Once born, I believe people have a right to live a full and healthy life. And to say that, well, it's a good thing a pandemic comes along because it takes, a certain segment of the population away, or it takes old people away. And I've heard it so many times. Well, it's just people in a nursing home. I find that really disingenuous. And I think that while I surely understand that, if a 21-year-old dies from the condition versus an 85-year-old who may have some elements of dementia, you can argue those are two different lives, and I get that completely. But the quality of who that person is any different. That might be my mom or my sister, or it might be my aunt. And so I think there's been this sense of, well, this isn't a really bad pandemic, it's just a bunch of old people. And I think that is the essence of ageism. I think that's exactly what I assume that's the genesis of your question, is that. And I have a real problem with that. And so, I know far too many people today that are living qualities of lives that I can't begin. Let me just case in point. Both of my grandmothers died when I was 63. When they were 63. And both of them were, aged as since before that. They were both in long-term care facilities for 6 more months before then. Back, in the 50s and 60s, that was old age. And, you could argue that, well, they were going to go, here I am, I'm already 5 years older than they are. And I feel still like, don't take a moment of life from me. I got a lot to live yet. So just that relative idea that just a generation and a half ago or one ago, that was old age. Today, that's not old age. So when people say, a bunch of 70-year-olds, do you realize how viable, how completely intact all their lives are and what they're doing? And so I have a real challenge with this. And maybe you're hitting a personal note with me right now, okay? I think we need to have more of that discussion. I refuse to accept the fact because somebody dies when they're 72 and they were of sound mind and body and being active, that's bad. And even to the extent that from a quality of life standpoint, somebody in long-term care deserves a much better quality of life than having to die alone because they couldn't have their family there.
Thank you, Mike. So well said. Question from Ethan Kerberg, class of 2021 from St. Olaf. Are garage gatherings with open garage door a reasonably safe alternative to outdoor gatherings in Minnesota this winter, assuming distancing and masking are still observed?
It's all about the air circulation. Let me give you an example. This is not going to set well at St. Olaf, okay, but we'll see. The worst sport you can play right now is hockey, indoor hockey. And we have a number of outbreaks associated with it. And people say, what? And the reason for that is, and our group actually helped first describe this problem 2 decades ago, in the 1980s, in fact, I'm sorry, more than 2 decades ago, where we had a series of outbreaks of people suffering very serious lung damage, hockey players, from poorly tuned Zamboni machines, the icing machines, that either put out carbon monoxide or nitrogen dioxide, depending on whether the mix was too rich or too lean. And what happened was the cold dome of the ice with the boards and the walls around it, the glass, actually held everything in. The air didn't blow out or move out, and it was like one big dense cushion of air. And so you could play in there for all, every period, and the air didn't change much, except you just put out more and more virus or whatever. The machine during each, period would put out more of the chemical. And today we're seeing large outbreaks in hockey because of that very issue of indoor air in that hockey arena. And so I only raise that because of the garage, because again, is that air trapped in that garage? And just because you have the door open doesn't mean you have ventilation, particularly if it's very cold, and how the cold relates in the garage versus outdoors. So I can't tell you. I mean, if you had air passing through, I'd say it's better. But, I would say, you want to make sure you have good airflow through there before I'd tell you that it's okay. Because in temperature inversions, cold air can actually sit down, be held in, and not move.
Thank you, Mike. This is from Sam Bailey, class of 2021. This is a big question. If the U.S. had a socialized healthcare system, how would our current situation be different, if at all?
I don't think it would be different at all. I mean, if you look at socialized medicine, look at countries in Europe, et cetera, they're experiencing the same problems, major worker shortages. It's not about access to care. It's about, is there anybody there to give you care if you want to have access? And so that's the challenge we have. So this really gets back to the fundamental practice of medicine and what kind of reserve do we have to build in so that if we have a surge need, that it's there. So, I can't say that, with the current Affordable Care Act, that means that everything is fine and taken care of. I do know healthcare systems are suffering mightily right now from delaying or postponing a lot of the procedures that brought in additional revenue. So, but I think from a socialized medicine standpoint, they have exactly the same problems we're seeing right now with a lack of trained workers available.
Thank you. I think we have time for one more question, and this is from Brendan Wessler, who's a professor at St. Olaf College, teaches in the Public Affairs Conversation program, is in the Department of Philosophy. Can you say more about the process for approving vaccines? To what extent is this a process that can be politicized, making approval dependent upon politics rather than science?
Well, for a vaccine to be approved through the FDA, it can go through one of several ways. It can be licensed, it can receive emergency use authorization, or it can actually even be approved on what we call compassionate plea. Each has different levels of requirement and different purposes for how it'd be used. In the end, it is the Secretary of Health and Human Services that decides that a particular vaccine would receive a designation of approval under one of those conditions. Our concern was that the current president said on multiple occasions that there would be a vaccine available before the election. We were concerned that that would be an October surprise in the sense that we want the vaccine out as quickly as anybody. Nobody's trying to hold it back. We got 1,000 people dying a day. We need this vaccine. But we don't want to put out a vaccine that has not been adequately vetted for safety and for efficacy. And so that was really the challenge. That's really gone now. There's no sense of that. I don't have any concerns about this right now. I have very strong support for Steve Hahn, the current commissioner of the FDA. I think that the regulatory science group at the FDA are among the best in the world. And, should someone try to put a political thumb on the regulatory scale, that'll be known right away, and there'll be a very loud and very, how should I say it, a kind of response. Let me just say that the companies themselves don't want early approval because if they did and they were accused of trying to go around the system and something happened with the vaccine, oh my God, the liability and the reputational issues would be career ending, company ending. So, I mean, they recognize their importance in terms of providing a very safe and a very effective product at the best they can do. So I don't think this is a problem anymore. It's a great question, because if we'd had this conversation 8 weeks ago, I would have had a different tune, as we saw that we thought that this might be a political move at this point, but we're fortunate that it didn't turn out to be.
Thank you, Mike. We've come now to the end of our time. Thanks to the audience for joining us tonight for this stimulating exchange with Dr. Mike Osterholm, Director of the Center for Infectious Disease Research and Policy at the University of Minnesota, and recently appointed member of presumptive President-elect Joe Biden's task force on the coronavirus. And thank you, Mike, for being with us in this very busy time in your life and for sharing your very special insights and general wisdom about public policy and COVID-19.
Thank you, Ed. And you remind me why I love liberal arts education so much. Thank you.
Well, thank you.
You're a masterful question asker.
Well, thank you very much. I enjoy doing it. This has been the last event in our fall series on the presidential election in a nation in crisis, polarization, pandemic, prejudice. Be on the lookout for our new series of events this coming spring, which will, among other things, take stock of where we are once the presidential election is resolved. You can keep track of Institute events at institute.stolaf.edu. That is institute.stolaf.edu. We hope you can join us next spring. For now, good night, be safe, and be well.